I'm Dean Kereiakes, and I'm president of the Christ Hospital Heart and Vascular Institute, a clinical professor of medicine at The Ohio State University, and deputy editor of JSCAI. I'm here this evening with Michael Foley, who's a clinical research fellow from the National Heart and Lung Institute, Imperial College Healthcare NHS Trust in London, Molly Szerlip, Associate Director of Education Research Program and Director of Cardiology and Structural Fellowship at Baylor Scott & White Heart Hospital in Plano, Texas, and Rahul Sharma, who's Director of Structural Interventions, Associate Director of the Cardiac Cath Lab, and Clinical Associate Professor of Medicine at Stanford University. We're here to discuss a manuscript that is entitled Aortic Valve Calcium Scores Associated with Acute Stroke in TAVI Patients. And to start, I'd like to ask Dr. Foley, who's the first author on this paper, to describe the study, its results, and clinical ramifications. Michael?
Well, thank you very much for that introduction, and thank you very much for having me on to discuss this paper. My name is Michael Foley. I'm a Medical Research Council Clinical Research Training Fellow from Imperial College London, and we've recently published this paper in JSCAI. Aortic valve calcium score is associated with acute stroke in transcatheter aortic valve replacement patients. So why did we decide to undertake this analysis? Well, we know that TAVR is the treatment of choice in patients with severe aortic stenosis and moderate or higher surgical risk. And it looks as if that TAVR is going to continue to expand and enter into even lower risk populations. And whilst it has a favorable profile that's usually acceptable to patients, we recognize that stroke is a known and potentially devastating complication of TAVR. From histological data we have from embolic protection device studies, we know that many post-TAVR strokes are a result of embolization of calcific material. And we now, in modern TAVR programs, are in a world where pre-TAVR CT is routinely available, and the aortic valve calcium score is routinely calculated from that CT. It has demonstrated utility in arbitrating between moderate and severe aortic stenosis in cases where the echocardiogram is equivocal, and we know that it provides some prognostic information as well. However, its utility, specifically looking at acute stroke post-TAVR, hasn't previously been demonstrated, and that's why we undertook this analysis. So our hypothesis was that higher aortic valve calcium score from the pre-TAVR CT would be associated with a higher risk of acute stroke post-TAVR. And to address this, we conducted a retrospective observational cohort study of 433 consecutive TAVR patients in a single centre, Hammersmith Hospital, which is part of Imperial College London. We excluded patients who had valve-in-valve or TAVR in the mitral position, and the calcium score was extracted from the pre-TAVR CT with stroke status and other clinical data extracted from the clinical records. We conducted a univariate logistic regression model looking at the relationship to an aortic valve calcium score, as well as age, pre-existing comorbidities, sex, TAVR manufacturer with stroke risk. And in the event that there would be multiple individual predictors, these would be combined into a multiple logistic regression model. And this is what we found. We had a fairly typical population for a UK TAVR program with a median age of 83. 12% of our patients had a history of stroke or TIA, 25% were diabetic, and 29% had a history of atrial fibrillation. The median calcium score was 2,145, and you can see the distribution of the calcium score on that figure there. And this was our primary result. There were 22 acute strokes in our cohort, and we did discover by logistic regression a significant relationship between aortic valve calcium score in the pre-TAVR CT and acute stroke. Additionally, we identified peripheral arterial disease, which is a known risk factor for acute post-TAVR stroke, and longer procedure time is also associated with acute stroke. Of course, that may not be causal. And interestingly, age was not an independent predictor of stroke. And when we combined peripheral arterial disease with calcium score, both remained independent predictors of acute stroke. So what do I think we should do with this data, and what do I think are the implications for practice? Well, primarily, I think that it's an interesting finding, but I think it should be replicated in other TAVI or TAVR registries around the world. However, I think that potentially aortic valve calcium score can form part of a individualized patient discussion about risk surrounding TAVR. I think that's going to be increasingly important as TAVR moves into lower risk patient populations who are looking forward to a long life with their new valve. And stroke is obviously a devastating complication in that patient group. And if we can inform a more nuanced individual patient risk discussion, and then I think that would be important. I think additionally, this might also have a role in refining our approach to cerebral embolic protection devices. And in patients with a high calcium score, they may have a particular role. And I think that would be an interesting avenue of future research. That is the paper we've recently published. Thank you very much for listening, and I'll be happy to take any questions and participate in the discussion. Thank you very much.
Thank you very much, Mike. A couple points of clarification. What was the prevalence of bicuspid aortic valve in this group, or were they excluded from analysis?
No, they weren't excluded. There was a low risk of bicuspid, or a low proportion of bicuspid valve in the region of 5 to 10%.
And did any of these patients have cerebral embolic protection, or was that not used in this?
No, none of these patients had cerebral embolic protection devices. I know in some centres and some programs that it's used routinely. Certainly in the UK, it's not in routine use. It's usually as part of an ongoing research program. And in my own institution, they're not routinely used, but that's an ongoing point of debate. And I think we're waiting for more data about for efficacy data before using them routinely. And perhaps this could form part of that.
Was either STS score or clinical risk stratification put in, whether they're low, intermediate, or high? And particularly when you look at your rate of stroke, 5%. In Partner 3, 500 patients randomized to TAVR where embolic protection was used in maybe 10%. There's one patient that had a modified Rankin score of 1. So were these more high-risk patients?
Yeah, so we didn't use STS score or any other risk score within the analysis. We wanted to look at calcium score as a univariate predictor. But I think we do calculate the STS score clinically, and I'm sure that the population we have would be probably at a higher STS score, certainly.
Mean age is pretty high. Molly and Rahul, I'm going to ask you guys to step in. And are you surprised by this finding?
No, I mean, it makes sense, that if you have a high calcium score on your valve, that you potentially have a higher risk of stroke. I saw that it was the median calcium score was 2200. What was the average calcium score, just out of curiosity?
Oh, I would have to bring up my data, but it was not too dissimilar. I'd have to have a look. I'm afraid I can't remember off the top of my head, but I'd have to look it up. But it was not too dissimilar, maybe 2400.
Okay. I mean, the only reason why I'm asking, because that's close to what we would use, in people with, because it was at least, what was there? Well, first off, was there a difference between male and female on your? I mean, there was a part of here, I was looking at your paper, and I don't think there was a difference, or was there a difference in that?
No, so sex didn't associate with risk of acute stroke. Though, of course, the calcium score was very different between men and women.
I guess I'm just trying to figure out if there was a higher calcium score, was it more likely to have a stroke versus a lower? I mean, because there's cutoffs for severe aortic stenosis that we use for like low flow, low gradient aortic stenosis, right? And I'm just trying to figure out what that is in relationship to what you guys found. Was it like 2,600 in men and 1,800 in female? I mean, because I'm just trying to figure out if there was a.
I think that was my question. That was my question too, Molly. And if I'm understanding you correctly, is it the independent predictive value of the aortic calcium score versus the aortic calcium being a reflection of the severity of the AS, which in turn
exactly
portends the higher risk of stroke. And that was a question I had as well. And to answer your question, Dean, I'm not surprised, but a couple of questions that I had for you, Mike. First of all, were the strokes or neurological events adjudicated clinically? I noticed that patients were included if they had a persistent more than 24-hour defect, but also those that had one within 24 hours, but neurological evidence. So you included TIAs. Did you risk stratify major versus minor? That's been a point of contention in terms of the definition of stroke in these patients as well. So that's my first question.
I think that's a really good point. So all of these strokes were determined sort of in our post hoc analysis, and they had to fit strictly to the definition that we'd used throughout the analysis. So for those strokes where the neurological deficit resolved within 24 hours, there had to be new or concomitant new neurological change on imaging, CT or MRI. And where there was a debate between the two assessors who were arbitrating on that, we would take a third independent party to review whether or not we were going to include that as a stroke in the analysis. And sorry, your other question.
So the second question I had was, one of the interesting risks for stroke in your paper was procedure time. And I couldn't find any information on the use of pre-dilatation or post-dilatation. One could presume that a longer procedure time meant that there were some difficulties in crossing the valve, perhaps access related, and whether, just interested in your opinion on how much of a role that may have played in those patients having a higher stroke risk.
Yeah, I think that's very likely to. It's difficult with a retrospective analysis to tease all of this out, but I think there are two potential contributors to that effect that we've seen. The first is that there's higher upfront procedural complexity because of the patient who's undergoing the procedure, and that's where the increased stroke risk is found. The second thing may that the stroke may be causative. It may be that the acute stroke within the procedure. And a number of the strokes in this study were diagnosed in the cath lab. That's what we're seeing there. That there's a prolonged procedure time on that basis. So it may not simply be the patient substrate. It may be a causative thing.
Yeah, that was my question, Mike. Is it collinear, meaning how many of the strokes were witnessed in the lab, and did that prolong procedure time? P-value for the procedure time is the most significant of your three variables. PVD is not new. It's been in other risk predictive models, both Vina Thirani's model that he proposed in Annals of Surgery and in the TASC score. Some of you guys recall in PCR 2019, the TASC score was rolled out, presented, and includes peripheral vascular disease, prior stroke, chronic kidney disease. Most of these models have included chronic kidney disease, interestingly, and that did not, in your number of patients you have, that was not a predictor.
No, that's right. We didn't find an association with chronic kidney disease in our population.
Were all of these done with the type of valve that would come out? Because that's come out in other analyses, whether you have a self-expanding or balloon expandable valve. Did that factor into this?
We did. There was no difference between balloon expanding and self-expanding valve. We did look at that between the two valve manufacturers used in our study, and there was no difference at all. Though of course we're limited by a relatively small number of events ultimately to determine that.
Now, in the absence of a cut point, Rahul and Molly, how are you going to use this? Obviously, badly calcified valve. So we almost don't need a score to come up with, but it'd be nice if you could say, if it's greater than 2,000, or if it's greater than some value, and it probably will be different for men and women, that this is a significant risk predictor, and we should incorporate it into our algorithm for determining who gets embolic protection. You guys are doing this right now. Molly, I'm going to go between both of you. Give me what makes you do embolic protection, assuming it's not 100%.
Yeah, so we have kind of strict criteria for embolic protection until we get more data onto whether or not it really does prevent clinical stroke. So we really only use it if patients, if we're doing like valve-in-valve, highly calcified bicuspid valves maybe, and recent stroke are really the only reason why we use embolic protection. And we just made up, and to be perfectly honest, we just made up our, I mean, that's really our own threshold of criteria. A lot of it has to do with data and the cost of the device, you know, and we're just not 100% sure that the embolic protection device that's out there now is the best device and prevents stroke. So
no, I guess we'll learn at TCT. Maybe that could be.
that's right.
Rahul, yeah. What's your algorithm?
I think not too dissimilar to what Molly's saying. I think to answer your question about the role of the calcium score, we use it more as a diagnostic tool when there's equipoise between the echo findings and our clinical suspicion, and it's very helpful there to stratify severity. Using it less so to guide the decision for the use of cerebral protection. I came from an institution where it was used almost 100% of the time to an institution where it was used very little. And now I'm somewhere between, and similar to Molly, it's somewhat arbitrary in the decision, very heavily calcified. But again, to your point, Dean, we don't need a score to tell us that. That's just an eyeball test to assess for the extent of, and we're talking about aortic calcification in this paper, but of course, there's the role of LVOT calcium, contiguous aortomitral calcification, heart calcium, and all of those, of course, contribute to the stroke risk as well. Aortic valve calcium is careful to exclude calcium from any of those other places when calculating these scores. So I think sometimes it gets very difficult to make it precise when there are a lot of contributing factors.
In the 22 patients who had stroke, was there anything about the access site? Was it, did that come up as, I mean, obviously most of these patients were transfemoral, but in the ones that you did do, like subclavian or transaxillary, was there anything that showed up there, or not enough patients?
There was no signal for an access site, though, as you say, we're pretty limited because I think 92% of our cohort were transfemoral, so it'd be very hard to tease out a signal based on those numbers. But it's an interesting point. I wonder if it. I mean, it certainly seems plausible that would interact as well, but nothing that we saw in this analysis, I'm afraid.
You know, it's interesting listening to your algorithms because we don't do it on 100%, but we've creeped up to 50% or more of the cases from originally not being very common to use embolic protection. Valve-in-valve, bicuspid aortic valve in particular, another group in part, not just because of the clinical events that have been described in series, non-randomized series, but looking at the number of diffusion-weighted MRI defects, the debris captured in tricuspid versus bicuspid, probably reflects the severity of calcification, to be honest with you, from your data put into the mix. And then some of us believe, obviously prior CVA, some of us believe in dialysis patients, probably for the same reason, that those patients, we tend to use embolic protection. And then patient request. It's a little surprising how many patients we see, and it depends on your demographics, actually come in and request that. Would any of you guys agree with that?
Yeah, you know, it's interesting. We have quite a few patients who come in and ask us about cerebral protection because they've done research, and we just go over what we know. And we tell them that there's just really not data out there. And then, you know, I would say maybe 50% of those are like, well, okay, use it. And the other 50% are like, nah, okay, don't use it. So I don't know.
Yeah, it's interesting. Well, I'm going to be using this. We're going to be quoting this, you know, because it makes sense. It's something we kind of intuitively knew. And we'll be looking at calcium scores prospectively, and I guess models going forward will probably include calcium score, or should, in multivariate analysis. Any closing comments that you would make, Molly? We'll start with you.
Wouldn't it be nice if TVT collected calcium score? Then we can look at a large registry population. It's not hard to do. We all have the information on every CT scan. It's really easy to get the calcium score. So it'd be an interesting one to put on to see if we can better tease out exactly what level of calcium, you know, is more at risk.
A great suggestion. Rahul?
Yeah, I think to follow on from that, it's great that some of the current trials like Progress are doing that. We're collecting non-contrast CTs with the view of getting calcium scores in a core lab format, so that we can look at it in terms of the prognostic value as well. Beyond stroke risk, I think there's a lot of prognostic information that we can get with the calcium scores. So I think there's a lot more work to be done, but this is very thought-provoking and just adds to the volume of additional information you can glean on the CT.
Yeah, I think my main takeaway from this is that there's a biologically plausible mechanism through which you can have an embolized piece of calcium causing an acute stroke. And this, I think, is more data to support that hypothesis. I think the next step would be perhaps a dedicated trial looking at ways of preventing stroke in a particularly high-risk population, and maybe just refining our approach to embolic protection. I think that would be, my own personal feeling about where we would next take this data.
I think you've made a significant contribution to our database, and one that we'll be using going forward, maybe incorporated into other databases. I want to thank each of you for taking the time, making the effort to be here in this conversation and interview. And I want to thank JSCAI for giving us this opportunity. So all of you in the audience should be on the lookout for this manuscript when it comes out and see how you can incorporate it into your practice. Thank you very much, Michael, Rahul, Molly. Appreciate it.